So, hi Oliver, thank you very much for sitting down to talk to me today. I've got a few questions that I want to ask you about your strategies in treating men with prostate cancer. The first question I have for you is, in terms of your treatment strategy, do you aim for maximum number of treatments or maximum time per treatment?
Well, I'd like to have both, actually. And by the way, thanks for having me. Pleasure to be here in beautiful Melbourne on a beautiful day. And, when we're approaching these therapies now, we almost always try to get in one of the novel hormones and one of the taxanes. And then what happens after that, it gets to be a little bit conjectural. There's some patients who might be good for radium. There's some patients who might be good for cabazitaxel. There might be patients who are good for some of the novel hormones after the taxanes. But in general, what we're trying to do is to maximize both the duration, where feasible, of course, as well as the alternative therapies to try to get things in. And sometimes, by the way, you can be very surprised. You don't always have it figured out. We had a little case the other day where docetaxel after docetaxel actually worked out really well. Surprising, but true. So one of the things I tell my patients is we've got to keep working at it. Just don't give up. Stick with us and we're going to work.
And keep a flexible sort of mindset about what you're going to do.
Absolutely. And, as we have clinical trials, we try to get the clinical trials integrated in the most meaningful and sort of robust fashion that we can. When I open a clinical trial, I'm opening it because I think it's going to be good for patients. And so the clinical trial opportunities will be present at various sort of intervals during the treatment pathway. And that's always part of the armamentarium as well.
So if you are starting treatment in one of those chemotherapy naive, asymptomatic men with advanced prostate cancer, what triggers are you using to change therapy?
So we're talking about chemotherapy naive, and are they on one of the novel hormones?
Yeah, so
on
perhaps you're starting Abi or
insulin, and that's typically where we start. We typically start with one of the novel hormones. That's about 90%. We use a little bit of simple cell T, not much, but typically it's the novel hormones. And then, there are a variety of things we kind of look at along the way. Tolerance or intolerance, the patient having trouble with the therapy they're on in a particular way. So toxicity assessments are always part of the background. It's not the primary driver because most people are just going to be, marching on through. And then the typical scenario is the PSA is going to rise. That's about 60% of the time. And then there are going to be radiographs that change. And then there are going to be opportunities for the patient to have symptoms depending on where that disease is. One of the things I have learned a little bit is you need to pay a lot of attention to the symptoms because the PSA actually is not the most reliable measure. And I could quote various studies, but the radiographic progression is a percentage, the clinical progression is a percentage. And when you're having clinical progression, you're often having some radiographic progression that you can find if you look. So yes, I watch the PSA, I watch the patient, I watch the radiographs, and a little bit of the 2 out of 3 rule that was at St. Gallen, but not perfect. If I have clear, unequivocal new liver mets, I'm not going to sit and watch them and wait for symptoms. If it's just a rising PSA and that's it, and I check it out, I'm pretty tolerant of that so long as it's going along pretty, reasonably well. I don't like these PSA doubling times of every 2 weeks or something crazy. But really, will I change just on PSA alone? The patient, the laboratory tests, including PSA, and the radiographs combine to sort of create a good decision-making process, I think.
Great, thank you. So I wanted to talk to you more about biomarkers, because obviously there's a huge amount of interest in biomarker development at the moment. How do you think, if some of these biomarkers come through into our clinical practice, how do you think that's going to impact what we're doing when we're using androgen-targeted therapies?
Yeah, so a couple of things here. And I'm going to put biomarkers into a couple of different categories. They're the prognostic biomarkers, which don't tell us a lot about the type of therapies we might choose. And then the predictive biomarkers that are actually associated with the therapy we might choose. And I'll talk a little bit about, the ARV7. And there are a couple ways to measure ARV7. That's the antigen receptor variant. 7 is the splice alteration. And you can pick them up in the CTCs on an RNA assay. You can pick them up on a protein assay with the nuclear and the new Epic Sciences. And here it would appear that when you're expressing that V7, that you actually are going to be fairly resistant to the hormonal milieu changing. And if we move to the taxanes, it's not predictive of resistance. So hormone resistant, taxanes not, and that might be a trigger to move over to one of the taxanes in that setting. On the other hand, if you are repetitively having no evidence of any AR changes, that might be a patient. You might even go from one of the novel ARs to the other and actually get some mileage. A lot of complexity here. I mentioned ARV7. There's so much more to the story. There's AR amplification itself. There's a circulating free DNA, which we can measure. And there are alterations in things like MYC and P53 that are also relevant. BRAF is actually altered in more patients than you might think. So as we expand our sort of genomic scope and we start looking beyond the AR, we're finding all sorts of stuff. And certain things we think might be actionable, like the DNA repair genes, the mismatch repair genes, stuff like that. But on the other hand, this is so evolutionary right now that we really need to get the data and the trials and just sort of teach each other how to do it best.
It's a hopeful time, isn't it?
Oh, it's very hopeful. No, I'm very, very hopeful. I feel like I'm smarter now than I ever have been before. I'm just hoping my patients benefit from what I'm hoping might be my own new information that I'm bringing in. And, that remains to be demonstrated, really. So I'm learning more, I'm analyzing more, but now I have to really demonstrate my patients are benefiting more. That has to follow.
So perhaps following from that, can I ask you, if we're stargazing a little bit, what do you foresee as the biggest change to practice in the next 5 years?
So there can be a couple of things. We have novel hormones, and they're going to move up. I don't think there's any question in my mind that we have these nice new, very active AR-targeted agents, and we've got a bunch of them. Everybody knows about avianenza, but we've got the apalutamide and the ODM-201 coming on as well. So they're now being looked at in a whole series of spaces. The non-metastatic space, at least non-metastatic by the usual CT bone scan criteria, and then the upfront state, and then maybe in combination with radiation. So I see a shift of the novel hormones moving up. That's, I think, going to be sort of ordained. Beyond that, I think the data on the PARP inhibitors and the DNA repair defects is going to be strong enough. I expect those phase 3s to be positive. So I kind of see a straight shot there. I thought the AKT inhibitor that Johan presented at ESMO was quite intriguing. Really want to see a big trial and see if they knock it out of the box on that. The whole issue with the PD-1, PD-L1, and very targeted subsets could be intriguing. But right now, I'm seeing several of these, quote, targeted therapies, and then I see the AR targeted therapies kind of changing. But I'll tell you what's really going to change is we start moving the AR targeted therapies up front, then what does that do to the natural history of the disease? And it might be very, very different than what we're treating today.
So I wanted to ask you a question away from therapy, but to ask you about the team that that is involved in your practice. Who would you consider to be members of the core treatment team for a man with advanced prostate cancer?
Yeah, so we have the very traditional medical oncology, nursing, and then of course we have the other specialties because quite often we involve the urologist and radiation oncologist. But I'll tell you what's interesting is how we're expanding out. So I have a PhD geneticist who comes to my clinic, and I have a person who does nothing but family histories in my clinic. And then I've got a translational lab that's right across the way. And then I have collaborations with a whole series of companies that are enabling me to do assays that I wouldn't be able to do otherwise. And so when I talk about, maybe getting a little bit smarter about how we handle disease, maybe smart is not the right word, better informed, you can't do that all by yourself. It really takes a team. And so geneticists and individuals in the translational setting, plus the radiation oncologist and the urologist, all forming together to create something that we think is hopefully better than any individual alone.
Nice. And actually, as the collaborations get bigger and bigger, it starts to be sort of state and country and worldwide teams, doesn't it?
We collaborate very, very, very widely. For many years, I've had close collaborators in Norway, in the UK with both Jan de Bono and Chris Parker that we've published with over the years pretty extensively, a little bit in France, a little bit in Australia. The opportunity today is not limited by any particular geography. We define collaboration about where common interests lie, not according to where you live.
Nice. Thank you so much, Oliver. It's wonderful to see you, and it's lovely as always to hear your wisdom and to get inspired by what's going on for men with advanced prostate cancer. Thank you.
Thank you, Carmen. My pleasure.